We've had accreditation on hold for a while and we've started all over again. So I imagine some of you are coming up to accreditation sometime in the near future. So a little bit about my experience with accreditation. I have worked in a number of practices, been in the industry, as you heard, for a while. In the very early days of accreditation, I used to have this horrible struggle with with all the preparation, getting all the documentation together, trying to get everyone to do the right thing, going through all the different records. And it was just really a nightmare of a process. We'd then get the surveyor out who'd inevitably find things that we hadn't done, and we wouldn't feel great afterwards. And it was always a real struggle that it became a mad rush about a year before we'd come to the actual surveyor visit. So eventually started in the practice I'm in now. We went through the same sort of struggle first time or two, and then after that second round of it, we said, this is really silly afterwards. Why do we keep repeating the same way of doing things? Why do we not keep this going, make it the framework for which we operate off, so using the standards for everything that we do? And why don't we keep it going with the policy manual really and truly becoming that living document? All the meetings that we got going, really making that happen for us, getting everyone on board and making the process a whole lot easier. So that's what we did. And we actually were one of the very last practices to go through accreditation before it all stopped this year. That was about the third time since we'd made that change. And it's become actually a really exciting process. It's still a lot of work in the lead up, obviously getting everything prepared, but it's a lot less work, and it's actually now something we look forward to very much as our time to shine. It's a bit of a show off, and it's an opportunity to get some feedback on the things that we're doing. So hopefully I can encourage some of you tonight to start to embrace accreditation in the same way. I can hope anyway. So it's at this point, it's a really good time to think about, why do we go through accreditation? It is a lot of work. I'm never going to say that it isn't. It really helps motivate us through the journey. And number one, let's face it, there really is a good reason to do it. And there's nothing wrong with admitting that a bit of a monetary incentive is a good incentive, and that is, of course, the PIP. There's also general risk reduction in lots of avenues of the business, including business reduction, as well as, in terms of various processes, HR, those kind of things. We hopefully will reduce the risk of patient misadventure. That's a really big one. And if we do that, hopefully we can reduce the risk of litigation. And a really big one is practice improvement. We're actually driving our practice forwards in a whole lot of different ways, including minimising risk, but also business development and all sorts of things. It can be really an amazing tool for the development of your business. Quality is not an act, it is a habit. And this is what I was talking about before, that, I used to myself go through the process of madly getting prepared and only doing everything in the lead up to the surveyor coming out, and eventually change it to becoming a habit. And once it becomes a habit, it's all about quality. It's about quality improvement. So hopefully, again, you can embrace that in your practices. So we've got a lot to get through on the 5th edition. I'm not going to waste any more time in the lead up. We're going to get cracking straight away. So as I mentioned, we've been on pause for about 6 months. I would imagine that most of you are going through the 5th for your first time. Maybe a few of you have already done it, but perhaps just interested to hear about anything different, particularly in the pandemic environment. So welcome to the 5th. Something you probably would have heard is that every practice has been given a 1-year extension. Something to note is that when you do actually go through accreditation, let's say you decide to go through it 6 months earlier, that will actually change when you're due next time. So that will then mean it will be 3 years from when you go through it next. So it's still a good idea to do a bit early, 3 months before your expiry date. So most, QPA and ACPAL are both saying you need to do it 3 months prior. But whether you really want to do it 6 months before, that's something you need to think about. So again, welcome to the 5th. So the biggest thing we want to know about is what's changed, what's different between the fourth and the fifth. I'm not going to dwell largely on the fourth at this point because it's been a while now that we've been working off the fifth, but there will be a few little comparisons there. So the first and most notable thing there, part of it is the explanatory notes. So when you actually look at the standards for general practice, you'll notice that under each criterion, there will be a heading called "Why is this important?" And this will give us an explanation of why this criterion exists. What are we doing this for? And if you may recall in the fourth, it didn't really do that adequately. It might have given us a little bit of information, but not much. So basically it felt like we had to do something without really having an understanding of why we were supposed to do it. Find it always helps a little bit. Then we'll have some information on meeting this criterion. So it talks about ways that you could meet the criterion, and there's lots of information. They're still sort of building on the why this is important. And then we move into demonstrating how you meet this indicator. So this is a list containing ways that you must meet this indicator and ways you could meet this indicator. We're going to have a look at that in a minute. Now, there's a really important word that comes out of this repeatedly with the fifth, and you'll hear me say it over and over, and it's the word intent. So if you recall before, we talked about the why. So when you're reading your criterion, really think about what is the intent in the why. Why are actually doing it? What are they getting at? Because it's really going to help you address the "you could" element where you're coming up with ways that you might address that particular criterion. Some other changes. So there's some changes to the indicators. So there's different wording to reflect, and you may or may not pick up on this. It's a bit of a more subtle change. So some of them are now outcome focused. So the indicator focuses on the outcome or the intent rather than the process. And some of the patient-centered. So they focus on what the patient receives rather than what the patient does. So that a really obvious one with that one might be about information that's given to the patient about practice or in different languages, that kind of thing. Practices can choose a number of ways to show how they meet the intent of the indicator. So I mentioned before the "you could." So there's not a prescriptive way of having to meet an indicator other than a few. We'll talk about that in a moment. There are a variety of ways that you can meet that criterion that best suit your practice. And we'll have a look at that again in a moment. But as you may recall from the fourth, some of these very prescriptive ones, if you had a very small practice, didn't really work in a small practice environment. And I think one that really stood out to me was the one about having a meeting and it must be formalised and you must show lots of documentation of that. And you still need to have a meeting of some sort. Don't take it that you don't need to, but you don't have to have absolutely formalised minutes and things like that. That won't work in a small practice setting. So lots of ones like that. But yet in some high-risk areas, there are still some prescriptive indicators, and you must, so it says must see evidence. You must provide the evidence that is listed in that particular criterion. Another thing you'll notice is that they now use blue and black font. And I just have to stop at this point and say I actually find, even though the fifth looks overwhelming on first look, that it's actually a lot more user-friendly than the fourth. It's laid out in a much better format. It's broken up in some very sensible ways. It's much more adaptable to the type of practice that you have. So you'll find that there's text highlighted in blue, and that demonstrates evidence which must be provided to meet the indicator. So again, we're talking about must. Then the text in black, and again, we're going to show this in a moment, is a list of suggested options on how you could meet the indicator, and it uses the terminology could. So it's not exhaustive. You can come up with other ways of addressing it, but again, you must meet the intent. You must meet the must element, the bit in blue, and really make sure you're addressing it properly. The other thing I would say to the could is ideally where you can, don't just address maybe one item in that list. Try and go for maybe another one. Have a couple of options there that you've used so that if you haven't quite covered the you could, you've got something else to fall back on. So that's a whole lot of talk, but let's actually look at it in practice now. So criterion C1.1, information about your practice. This should be quite familiar to you all. It still exists as it has in the fourth and the third, and I think even the second. So this is the one about the information about the practice. Now, what you will probably recall is in the fourth, you had to have a practice information sheet. This really looks quite different now. So it gives you the why. It's really quite brief. It's about providing information about practice, including range and cost of services, and saying that it's important to all patients. So then we go into meeting this criterion, the format of the information. So it's talking about the various kinds of formats that you can use, such as printed information sheets, still allowed to do that, text on your practice's website. You could use pictures, you can have different language versions. There's a whole variety of things already mentioned there, but it's giving you that information of what you can use to work out the intent, to work out how you might address it. There's still that little bit there about advertisements in your practice. So that is that you must, notice it's in blue. So you be very careful about any advertisements in your practice information. So before you weren't actually allowed to do it, now you can, but you must have a disclaimer. I would really advise that you steer clear where you can. It's probably easier. So then we actually go into the list of what you could do to actually address this criterion. So C1.1A, our patients can access up-to-date information about the practice. So blue font, you must make practice information available to patients. Pretty easy. Update practice information if there are any changes. So it must be up to date and relevant. Now, I haven't provided it all in this list, but there is a list of all the information that you must provide at a minimum. So whether you do this on a website or whether you do this in an information sheet or a plethora of other ways, you must at a minimum address the required information. And again, you must make sure that it's updated. So update it when it changes. So they've got a list of things you could do. You could create and maintain an up-to-date information sheet. I'm sure that most of you are very familiar with this, but it contains all the required information in a language that is clear and easily understood. Now, you might have a demographic that really, predominantly languages other than English. It might be one predominant language. So let's say that you have predominantly Arabic-speaking patients in your patient base. Then you would probably want a patient information sheet in a language that is clear and easily understood to your patients. Always good to have an English one as well, because there are many patients that still speak English. You could create and maintain an up-to-date website, but it must be up-to-date, that contains all the required information, again, in clear, simple language. You can provide alternate ways to make information available to patients who have low literacy levels. So provide versions in languages other than English and versions including pictures. You could have signs in the waiting rooms. You could have brochures in the waiting room. You could have one of those digital notice boards, the TV screens that many of us have now. You could have other ways of doing this. You could get quite creative, and some practices certainly have. So you need to think of what works for you. Definitely in this one, I would have more than one you could. I would not just rely on the practice information sheet. I would probably have something else. And if you have a website, I most certainly would have something else, assuming that not all of your patients will refer to your website to get that important information. So I think that makes it a little bit clearer. So another thing about the 5th edition is the layout. It's a little different to the 4th, and I think it's far more logical in its format. So it's now based in module format, and there are 3 main modules. There's the core module that covers a lot of the business side of things, HR, all that kind of thing. Then we've got the quality improvement module, and then we've got the general practice module. Now, the reason it's laid out like that is so that it can be interchangeable in other settings. So, for instance, immigration detention centres, in prisons, in other settings as well. I believe it may also be used in specialist practices where it is voluntary. You'll also notice that there's a number of new indicators. Don't panic, because these are actually sometimes merged indicators from the 4th. they may be replacing an old indicator. There's actually not much difference in the number of indicators now. It's reasonably the same. So next thing, mandatory and aspirational indicators. You're probably familiar with this already from the fourth. So the indicator that marks whether it's mandatory or aspirational has changed. So when it's mandatory, it's a triangle now instead of a little flag. Of course, when it's aspirational, there is nothing. But I wouldn't get too excited about the aspirational ones. There's not very many of those. I think there's about 4 or 5 in total. We'll go through the 1 or 2 of them a bit later. So subtle changes in inclusions, there's a few new things that have appeared in there and a few things that have been teased out and given a little more information. So one of them is about interpreters, so registered. So the translation service must be, you must have your doctors all registered through that. You cannot just rely on family members. It's not appropriate, particularly for clinical situations. At reception, no, not so much of an issue. And you must be registered for the National Relay Service. There's a little information about the shared health summary, particularly to do with my health record in the explanatory notes, but it's not a required criterion at this point. It may well become one later down the line, who knows. There's information on costs associated with care initiated by the practice, and there is in fact a criterion associated with that one now. Health promotion, there's more information on health promotion. We're obviously moving more towards patient-centred care, making the patient more responsible for their own health care. There's more information, so there's the resources list, which is fantastic. And I really strongly suggest you get a hold of this. So if you go to the RSCGP website, you go into the accreditation. So actually it's managing a practice accreditation tab. And in the 5th edition, you'll actually see a number of things there, including the actual 5th edition to download, the infection control guidelines, and also the resources guideline or resources list. If you download that in PDF format, you will have this huge amount of resources you can go to that just makes it so much easier. They're all links, so you can click on them and it'll take you to wherever the shortcuts are. Trust me, there's not much point in printing it. Keep it in a digital format on your computer so that those links actually work, unless you want to type them in. The next thing that's noticed that's now included in it is antimicrobial stewardship. And you might be scratching your head wondering what that is. That's really about antibiotic use. So it's about encouraging appropriate use of antibiotics and about reducing the risks associated with it. So resistance, costs, and what else? Inappropriate use, really. There's also mention of clinical outcomes improvement and measuring. There are actually minor criterion based around that, but this is probably something that we're a little better with now thanks to the PIP-QI for all of those of you out there that are registered with that. So that's enough background about what's generally changed with it. Let's actually go into these new indicators to break it down and make it a little easier for you. There's definitely a few in here that are stumbling blocks when I go out to the practices, so hopefully I can help you with this. So the first one, C1.4C, our patients can access resources that are culturally appropriate, translated and or in plain English. So this is about what is appropriate to the demographic of your practice. If you happen to be in an area where all of your patients speak English, is it culturally appropriate for you to have material in other languages? Not necessarily, but you might want to have a few resources on hand for the odd patient that might come in that doesn't speak English as their first language. So you could have some websites to refer to. On the other hand, you may be in an area where your practice sees, again, patients of one particular cultural background or multiple cultural backgrounds. And so you could have information sheets in common languages. That's really, really helpful. But the other thing that is really important these days is to have a list of really reliable, credible websites that your patients can go to, and maybe you can refer to as well yourself, with information in other languages. So I've got some handy websites there. They all have information available in other languages or links to reputable websites where you can get that. In terms of getting information sheets in other languages, there are many available in a variety of languages, particularly the government ones. They're really great. So there's lots of brochures available on conditions like diabetes, asthma, pregnancy, a whole lot of different things, and you just really need to have a look at the various resources out there to see what you can find, but definitely have some on hand in case you ever need them. And actually, I should just go back. You may be able to find other ways to address that. Remember that that's a you could, but make sure that you do address it at least in one way, if not a multitude of ways. Our clinical team considers ethical dilemmas. So this one is a bit of a tricky one we're finding in practices. So you must document any ethical dilemmas that have been considered and the outcome or solution. Now, I will say that some of the GP surveyors are actually looking for this in the patient records, if it's particularly relevant to the clinical care of the patient. That is, if a patient is involved in that dilemma. You need to think of what ethical dilemmas are. And some of those dilemmas are things such as termination of pregnancy, morning after pill, religion and cultural issues. It could be family member, a friend coming to you as a patient. In a country town, you may actually have staff members that are patients of the practice, or also, in this case, you're not from country town, but you may have staff that are patients, and that's something you do need to be very careful of. Gift giving, that can be a real issue. Now, little small gifts is generally okay, but you need to decide on what is okay and what is not. You know, obviously getting a bottle of Grange, and there's a case study about that out there, I think Avant has it, is really not, it is certainly an ethical dilemma, because there's an expectation of higher level of care when a patient may give you something like that. And you know, leaving money in a will, that can be an issue, all sorts of things. So you could come up with what a list is of ethical dilemmas that you may face in your practice, and then a way of addressing that. So you might have a policy or procedure that explains how the clinical team may manage ethical dilemmas. You could discuss ethical dilemmas at clinical team meetings. And if you've got a larger practice, I would really strongly suggest that you do that and actually minute it. You could provide a buddy or mentoring system in which ethical dilemmas can safely be discussed, because you may not want to discuss it in a large team environment. You might want to quietly discuss it with one person that you trust. You could use a clinical intranet or group email. Obviously, this needs to, you need to consider privacy with this. So you may, unless you are assured that it's secure, you should not actually mention patient names. If it's secure, you may, but you need to be very careful. So, for instance, if it's medical director or best practice and you're using their internal messaging system, it would be safe to use patient names. If it's anything outside of that, I would strongly suggest that you don't. But certainly you could use that to come up with solutions to consider and discuss. You could display a notice in the waiting room listing ethical dilemmas, so in particular about gift giving at this time of year. For those of you that have school children, you've probably seen some notice coming out from the school suggesting a limit on gift giving, and that is along the same line. So that might be something you want to do. So you could think about other things you could do to address ethical dilemmas, really what would work in your practice. But you need to provide evidence to the surveyors when they come out of what you are currently doing and what you have actually done. So remember, that have been considered and the outcome or solution to address an ethical dilemma at some point. So if it's not in a clinical record, it most certainly should be in the minutes of the meeting, or it should be documented somewhere. The next one is C3.1a. Our practice plans and sets goals aimed at improving our services. So this is a really tricky one. It certainly has thrown a lot of practices, and I know that many practices sort of shrug their shoulders and say, what has this got to do with accreditation? Why are they making us, you know, do business planning, etc.? And it's really not about big business planning. It's about quality improvement, which is what accreditation is really all about. So if you recall, in the 4th edition, I think even in the 3rd, there was that question about, in the last 3 years, what improvements have you made in your practice? Now, as a surveyor, I can't tell you how many times I really had to try very hard to get an improvement from the team when I was chatting with them that they'd made in the last 3 years. And it wasn't just on one occasion that I'd been told they had purchased a new kettle or they bought a new bin. I really find it very hard to believe that in any practice in 3 years that's the only improvement made. So I do think that quite often when something has changed, that improvement has not been recorded, and therefore you're not able to go back on that. And it's not about really big, massive changes. Sometimes it's smaller ones. It might be you've had a look at the recall and reminder system, you've made some tweaks to it to make it run a little more smoothly, make it a little more safer. It could be you've looked at the staff induction system and you've overhauled something there. You've looked at your recruiting process. You might have changed something there. It might be bigger things. You've improved your communication with patients. You might have improved some clinical care. There's a whole lot of things that you could have done. But what this is about is not just documenting the changes you've made. It's now about planning for some improvements. It's not just that something's gone wrong and now you've had to fix it. It's actually looking to the future, saying, what are these things that we should maybe change, and then actually plan it and work on it, assess it, make sure it happens, and maybe review it later. So for any of you that are familiar with the Quality Improvement Cycle, PDSA, it's all Plan, Do, Study, Act. We're planning for our improvement. We're documenting, we're making sure these things happen, and we're assessing it to make sure it really worked. So the other side of that I've really just covered nicely is C3.2b. Our practice evaluates its progress towards achieving its goals. So again, no point putting these wonderful plans in place and then not actually coming back and having a look to see A, that it's been completed, and B, that it's actually been effective. Maybe it's not working. You actually need to scrap it, or you actually need to modify it in some way. So how do we achieve this? It's all well and good. You actually need to have some evidence to prove that you're doing this now. You can't just list the things that you've done. So there are two ways. And if you look at ACPAL's website in QBay, they have a business plan available. If you look in many other areas, there are business plans available. I'm not quite sure what QPA's got available, but I suspect it's a higher level approach as well. The PHNs I'm finding generally have a much more simplified version of goal setting documents, and this is really a good way to start off, especially for your first attempt at the 5th edition. If you're a really large practice, you might be already doing this, and so no reason to change it. If you're already doing it, you can always use what you've got. What I would say though is that if you've got a really big business plan with all your big improvements listed in there, about starting another site, or you're going to expand, and it's got your financials and things like that in there, you really don't need to be showing the surveyor that, and I would say it's not necessarily appropriate either. So you could perhaps have a simplified version that you show them. Of course, we're all bound by a confidentiality agreement, but I know many practices are not comfortable with that. I can understand that. So here's a simplified version. You can do this in Word. You don't need to use any particularly fancy program. You make a table. You put, as I've got, goal, description, the deadline, because deadlines are really important to make sure things happen. Who's responsible? Now, you might be a really tiny practice. You're responsible for everything. So in that case, you may not need to do that. How are you going to measure that you've actually made this happen, and record that it's actually been completed? So you could do this in any way that you want. This is, again, a you could. There's no specific way that you need to achieve this, but you just need to be showing that you're planning. So in the PHN documents, usually there are 3 goals: the short, the medium, the long-term goals, and practices seem to be quite comfortable with that. So you could do something similar to this, or you could put a whole lot of plans there, whatever works for you, as long as there is something planned and it shows not just that you've planned it, that you've actually completed some of them, and that also you've measured it to make sure that, just going back, you've evaluated the progress towards achieving the goals. Now, we again could go the whole hog. we could develop a business plan. And there are lots of business plan templates out there. If you haven't already got one, you can certainly download one from there's a multitude of places. And you've just got to find one that works for you. So the next one that is quite similar, I think kind of actually work quite hand in hand with the business planning criterion, is the business risk management question. So C3.1C, our practice has a business risk management system that identifies, monitors and mitigates risks in the practice. Now this one really throws a lot of people because this is quite unfamiliar to most. If you've completed the certificate or the diploma of practice management, you may well have come across a business risk management system. Maybe you've come across it somewhere else, but for the most people haven't heard of this. This is commonly used in other business arenas, not so much in healthcare as yet. So what I strongly suggest you do, if you're not familiar with this, is to set up a simple business risk management system. So again, go to Word, set up a table, a very simple table. I really strongly suggest that you put in period as a column, the issue. I also like to put in the topic area, and I'll show what I mean by that in a minute. The treatment that you're going to use to address the issue, who's responsible if it's not just you doing everything, and when it's supposed to be completed by. Now, just talking about the who's responsible side of things. So again, in a larger practice, it's really good if you can involve your team in some of the tasks of accreditation. It really brings them much more on board. It gives them buy-in, gets them much more involved and often more enthusiastic. Obviously, you want to pick the right staff for the different tasks, but if you do have the luxury of people that you can get to help you do these things, do that. And it may be that you're overseeing it and they're assisting you with it. It doesn't really matter. Just find a way to involve them. So, and obviously some business risk areas are not appropriate for other people to help with. It depends on the structure of your practice. So if we look at a period, I like to recommend a quarter because it's a nice big period of time. You can pick one or two different issues. And let's say that we're going to start with, remember I mentioned topic, we're going to look at ATO or compliance. So we're going to look at an issue. So we think of any issues to do with the ATO or compliance that might happen in our practice that is a real risk and that we need to do something about it. So we think about, I realise that PAYG is not always lodged on time. We better do something about it. Now that's actually quite a simple one to fix. What is the treatment? Set a recurring reminder in Outlook. That's going to help. Then you might want to make sure that you're accountable to it, but at least that's going to really help. Who's responsible? I'm assuming in this case, Kate is the practice manager, and then you're going to put in that it's completed. So this is just about saying that you've put the recurring reminder in Outlook. Then we're going to, we've actually set 2 for this quarter. Another thing we're going to look at, so actually I think we're looking at HR in this area because we're looking at PAYG and timesheets. So timesheets are not always accurate. That's another thing we can think of, and we really want to fix that because there's a whole lot of problems associated with that, including Fair Work. You really don't want them knocking on your door. So you could introduce something like Deputy or some other similar system in your practice. I know some are using that. That works really well. But you could think of other ways of doing that. It might be just overseeing the timesheets a little more than what you've been doing. Who's responsible? The practice manager. And completed date, well, it's in progress at the moment. So then we look at the next quarter. We've now come up with something to do with billing. So obviously our 2 topics there are based on that. So patients are not always paying at the time of consult. Well, that is a real problem, isn't it? We want to make sure that they're paying, not chasing that up. So hopefully you're dealing with this before you end up with enormous debt that you're now chasing, and the practice is starting to slide into bigger problems than just the little initial thing of chasing a few naughty late payers. So you need to review your private payment system. Who's responsible? Maybe your head receptionist if you have one. When's it going to be completed by? Obviously that's continuous. So the review there might be an initial review, it might continue on, and obviously the treatment's going to keep going. Another one would be Medicare may not be reconciled properly. So that's a real problem as well. If you're not actually reconciling, making sure the payments are actually all coming in and correctly done so. So that's down to someone else, and it's also in progress. So what I suggest as well is that you actually plan ahead. So as you're doing things, inevitably we all do this. In the course of our day, we come across something and we think, oh, that's a bit of a problem. That could really blow up on us at some point. Add it to your list. So decide that in the next quarter, I'm going to treat that problem. And then something else might come up. You add that, add something else there, and you might swap them around. If something becomes more urgent, move the more urgent issue to sooner rather than later, so that you don't leave it as a ticking time bomb. We don't want that in our practice. So I mentioned before about different topic areas, and there's something called the umbrella of risk. And that really helps to break up the potential business risks in our practice, so that we can think, gee, I don't know what area to look at. This really helps us a lot. Now, bear in mind that this is very broad. This is not just based on healthcare. It's obviously based on really any industry. So you can make this more specific to you. You don't have to cover all these different areas. You can pick what suits you best. But generally speaking, we've got people. So that's HR more than anything. We've got infrastructure and assets. Well, that's a really, really good one to look at, isn't it? Fraud, definitely something to look at. And I don't know how many of you are members of any of those practice manager networks out there, or a GP network out there. And I'm sure you've heard also from Avant or any of the other MDs of countless cases of fraud. So there's definitely something to be looking into and trying to tighten up on. Finance, making sure that that's all running well. IT, it's a really big area. Business interruption. So is your insurance appropriate? Have you got the right level of cover? Have you got all the kinds of cover that you need? Project risks may or may not be relevant, going by what you're doing at the moment. Compliance, covered that. Legal risks is definitely an issue, and we can think about things like privacy, ASIC. There's all sorts of different areas that you can look at. Customer quality is incredibly important. Strategic and political, that sometimes becomes incredibly relevant and not at other times. I think this year it very much has been. It's somewhat political, but strategic, definitely. I mean, how we've had to deal with COVID, and you could think ahead and say, well, we really need to deal with this now. So we'll push other things out and deal with how we're going to keep patients coming to our practice, how we're going to manage telehealth, how we're going to manage all these changes. And if you've done that, you could definitely add that in. If you haven't already got one of these in place, add that in. COVID, the strategies you came up with is managing some of the business risks there. What I strongly suggest is that you make it a cycle of 2 years. So when you get to the end of 2 years, go back and look at those areas that you've already done and address them again. How did it work? So if we just go back quickly, PAYG not always lodged on time. Is it lodged on time now? Yes, great. If not, we need to readdress it. And you may find other areas in HR that now need a bit of an adjustment. And same when you get to the billing side, have they worked, the treatments that you've put in place, or is it dragging along? Do you need to adjust it? Those kind of things. Okay, our practice has a policy about the use of email, and our practice has a policy about the use of social media. These are really problematic criteria that I find. So this is a completely new one. It certainly wasn't in the fourth. It was alluded to a little in the privacy policy, but not specifically. You now must have a specific policy for both of these criteria. You can't just have it sort of fit into another policy somewhere. You must have very specific and distinct policies on both email and the use of social media. So this is not just about saying our practice does not use email. This is about saying, okay, our practice does not use email. However, you might want to also talk about staff usage of emails. Is it okay for staff to access their personal email on your computer system? I'd imagine in most practices that you probably not be very comfortable about that. The risk of all sorts of things going wrong from that, clicking on links, clicking on dodgy emails, all that kind of thing can really terribly affect your computer system. So you may want to have something in that email policy about that. You might want to have something in the email policy about doctors using personal email addresses to communicate with patients. That can be really problematic, because if you have someone that sends an email saying, I'm having chest pain because it's out of hours and I can't get through any other way, and you say don't have an automatic response that says, we will reply within 48 hours, and if this is an emergency, please call 000 straight away. Unless someone is actually monitoring that email all the time, that could be an enormous problem. So you really need to have that addressed in there as well. If you do use email in your practice, then you really need to have a lot of information about that. So an auto reply, most definitely, what is the information in that? How do you maintain privacy if you are sending any documents, so things like password protection, all that kind of information. Same goes for the use of social media. So you may not have a website, you may not use Facebook, you may not use a whole lot of other social media means. However, that does not mean that your staff are not using social media. So is it okay for them to use it on your computers in the practice? Is it okay for them to use their phones at reception or in the treatment room or wherever, accessing social media when they're supposed to be working? Is it okay for them to take a photo of the waiting room, and much worse with patients in it, and put that on, say, their Facebook page, or name a patient, or all sorts of things that they could do, that if you don't have a policy saying that they can't do it, when that actually happens, what do you have to fall back on? It would seem obvious, but you really need to have that documented somewhere, what they can and can't do. Of course, you may also want something in there about monitoring Google reviews, or, not that you could do very much about it, but keeping an eye out on what the reviews are on your practice. You may not want to know either. Keeping an eye out on Facebook to make sure a patient has not set up a Facebook page for you. And believe it or not, that has happened. So you may want to do a review every few months to make sure something like that hasn't appeared. If you do have social media, you need lots of information around that. So what should be in there? What platforms do you use? Who is going to post on there? Who's going to moderate it? Who else has access? What is permitted? What is not permitted? How often are you going to put information on there? How are you going to make sure that it's relevant and updated? So there's a lot in these two criteria. It seems like nothing much, but there's really quite a lot. And let me tell you that if you have a policy that just says we don't use email or we don't use social media, that's really not acceptable. It just doesn't address it enough, because it's about the use of in both cases. So where do we get information to help us with this? Because this is a really big one and it is tricky if you're not familiar with it. So definitely have a really good look at the 5th edition. Make sure you understand that standard and criterion in particular. Make sure that you look to the 5th edition policy and procedure manual template, at least just for those particular criterion. So what have they got there? You may actually want to copy those templates and insert it into your policy and procedure manual, unless you decide to do a complete overhaul and go with the 5th version. You may want to contact your MDU, and let me tell you, they are brilliant with these particular ones, because it's in their best interest for you to get this right. The RCGP website has lots of resources available. There's actually a fairly decent guideline on that. AHPRA website, certainly information on there as well. Note that this policy must be specific to your practice, and also there are various laws out there that you probably want to be aware of, particularly for using social media to do with things like false advertising, testimonials, etc. But a lot of that's listed in the AHPRA website and the RCGP website. So do make sure you spend a bit of time on this one, really fleshing it out well. Our practice seeks feedback from the team about our improvement systems and the performance of these systems. You must keep a record of feedback from the practice team about quality improvement systems. Totally different. It's a little alluded to in the 4th, but not really about keeping records and things like that. So you could Have notice boards or suggestion boxes the team can use to contribute their ideas. So much like you had a suggestion box for your patients, you can now have a suggestion box inside the tea room, somewhere like that, where they could anonymously put suggestions in. You will sometimes get funny suggestions, I warn you, but that's okay because sometimes you'll get relevant and useful ones. You could have a notice board. Obviously, there's some rules around what can go up on that notice board, but certainly that is an option you could use. You could create a short survey, and many practices have done this. A lot of them have actually used SurveyMonkey, but there's other options as well. It could be paper-based, it could be an email, although email's a little more tricky. But whatever works for you, you could create the short survey for them to complete that are incorporated into a quality improvement plan. You could also, and I'll hope that you're already doing this, whether you're in a large or small practice, medium, multidisciplinary, doesn't matter, that you're having regular meetings. Now, in a large practice, you're probably having formal meetings. I would hope that you have an agenda. I would hope that there are standing items, but if you don't, I really encourage you to have some standing items added into your agenda that always reside in there, and one of them should be on quality improvement, and in quality improvement, one element should be on feedback. So that will be about staff feedback, and that will also be about patient feedback, any feedback that was received. So staff will not always be brave enough to raise feedback at that time, but if they are, that's wonderful. It certainly gives them an opportunity. Make sure it's minuted so that you then have documentation of that, and then you might want to go on to getting more information and documenting what you did about that. In a small practice, obviously you'll have a smaller meeting. Still a good idea to have an agenda, still a really good idea to keep some notes, even if it's in an exercise book. Still a good idea to be keeping records from your meetings, and certainly about important things like quality improvement and ethical dilemmas, all those kind of things that come up, and make sure that you're doing it regularly. Another thing that you would probably employ, I certainly do in my practice, I very much have an open door approach. My director very much has an open door approach. That's really important. You want to make it very comfortable for your team to come and have a chat with you. Okay, sometimes they're uncomfortable conversations, but sometimes they have really good ideas. And as awkward as it may be to hear it at first, it can actually really help with improvement of the practice in various areas. They might actually identify something that you didn't realise was an issue. So do hear them out, give them that opportunity. Try and just not take it on personally, but rather use it as the opportunity to maybe find out something that you can do to help. Okay. This is another tricky one. It's throwing a lot of the practices again. QI 3.2a. QI actually refers to the quality improvement module, if you remember earlier on. So our practice follows an open disclosure process that is based on the Australian Open Disclosure Framework. Now, I want you to notice one thing that is different from this one to the previous one. Can you see in this one, there's the little triangle. If you notice in this one, there is not a triangle. So this is an aspirational indicator. It's one of the very few, and that is because this is very new. It's encouraged at the moment. It's not mandatory, but I would strongly suggest that you're working towards it, because as many of you know, if it's an aspirational indicator, it's highly likely that it will become a mandatory indicator in the next edition. So we're talking 6, seems awfully an awful long way off, but you'd be surprised how quickly that lands on our doorstep. So the Open Disclosure Framework is hopefully something you're reasonably already doing. There's certainly some good guidelines available that you can read, particularly this one here. But this is really about if something goes wrong in the care of your patient, that you let the patient know as soon as you possibly can and help them in the resolution of the problem. So it could be something like you have somehow not contacted them about a result. Now, I strongly suggest that if it's something significant, that you would actually contact your MDU immediately. As soon as you realise that this has happened, get their support on this and call the patient immediately afterwards. And I'll certainly tell you, you need to do that. But at least you have that support before you even do that, so you know what to do. You'll then need to let the patient know what's happened, and you'll need to support them through whatever needs to be done to hopefully resolve the issue. So it may be that if it may be just if you're giving them a result and you're saying, I'm really sorry about this, here's a result, and that's the end of it. But if it needs follow-up, further treatment, that kind of thing, that you're trying to get them in as quickly as possible. And whatever else your MDU is suggesting in terms of patient welfare, they might feel a little traumatized by this, so you need to do something hopefully to help with that as well. So this is something we're working on. I think a lot of practices are already doing this. We really can't afford to sweep things under the carpet, because it's probably only going to come back at you in a much nastier way later on down the line, and I hate to think of the outcome for the patient. So again, contact your MDU and get onto this as quickly as you can. Document what you've done. Sometimes this is relevant in the patient record, sometimes it's not. Take your MDU guidance on this one. Now, this is a mandatory indicator. GP 2.2e, high risk, seriously abnormal and life-threatening results identified outside of normal opening hours are managed by our practice. Now, I know when this first time came in, there was certainly a lot of concern in the practices about this. There was this real concern that somebody would have to go into the practice and access the records and manage the patient from there in the middle of the night. And that's not really the intention of this. It's really that. So say that a pathology company calls you in the middle of the night, that you call your patient, and if it's seriously abnormal, particularly life-threatening, that they most likely will need emergency care, that you are directing them to emergency care at that time. So you're not just assuming that they will actually take care of that themselves. You are making sure that they get themselves either an ambulance or get to the hospital absolutely as soon as possible. And if they don't answer their phone, you may need to do something about that. You may need to call the police to go there and check them, or call an ambulance, whatever you think needs to be done. But the whole point is that you're not just leaving it to someone else, so the deputising service to deal with, you're actually taking care of this. Obviously, then the next day you need to follow up and make sure that the patient did go to the hospital, what's happening, that kind of thing. You make sure you document that in your notes, whatever you would need to do to make sure that the advice you gave has been followed up on. The next one is, and again, mandatory one, GP 3.1c, a clinical team is trained to use the practice's equipment that they need to properly perform this role. Now, this one is often forgotten as well. Also, you need to make sure they're aware of the potential risks associated with the equipment they use. So we're not talking about your average kind of equipment, thermometer, stethoscope, those kind of things. We're really talking about some of the high risk and more serious equipment. We're talking about your ECG, your defib, if you happen to have one, your spirometer, believe it or not, that is a really important one, audiometer if you've got it, Doppler, any other equipment that is complex, a little more tricky to use, things can go wrong with it, then you really need to make sure that that training is placed. Think about litigation. If something goes wrong, you say your patient is okay, and it ends up spiraling, with this patient with a poor outcome from some mistake that was made, what's going to happen when it goes to court? They're going to say, well, what training did you have on that piece of equipment? You want to make sure that that is documented. So that's where this has come from. Another one also that you could add in there is a height adjustable bed, because I'm not sure if you've heard, there has actually been the death of a child thanks to a child playing around with the pedals on the height adjustable bed. Seems so simple, but you can provide that training in 3 seconds, and also make sure that the pedals are not somewhere where a child can reach it. So just a little other one you could add if you choose to. But certainly the ECG and the defib are really important, as are these other ones. So who can do the training? Any clinical person in your practice that you designate to do it, but then you need to stick to that one person doing it. What qualifies them to be able to train everyone else? At the moment, there's no actual real requirement for that. I suspect that probably will be tweaked at some point. But as you probably know, when you get your equipment calibrated, very often they're able to provide some training as well. And that's becoming more and more commonplace, particularly for your defib. So if you can get that, definitely get that, certainly for the person providing training. Equally, we also need to make sure that we train for the risks. So you can imagine with a defib, you need to stand back. If you don't stand back, there can be a really nasty result for the poor person using the defib. ECG, make sure you get the leads the right way around, that, you know, that they have actually stuck properly. Those kind of things need to be said. With those high-risk ones, ECG and the defib, if and ECG is if your practitioners use them. If they don't actually use the ECG, then you can say they don't use it, and the only person that uses it of the nurses or whoever, and then they have had that training. That's acceptable. The defib, really, if you've got one, everyone needs that training. So it's for clinical staff. So again, you need to have the risk documented. So I would actually add an extra column into this one. I've added at the bottom, but probably column's easier, and just say discuss the risks of this equipment so that you've got that documented as well. Make sure that is completed by the time the survey comes out. GP 4.1F, our practice records. So this is only relevant in practices that still sterilise. Not very many of you out there now. Mostly practices are using single-use disposable instruments. But if you do, you must, actually, sorry, this is an aspirational one. It's moving towards you must, but I really strongly suggest you do this, that you record the sterilisation load number in the patient's health record, but also in a reverse log. So probably in a book where you actually keep the printout of the actual load. I think most practices do this now. They keep a record of the instruments used. I would then also add the patient's names against the instruments used in there, so that if something goes wrong with one of the loads and you need to now find out who has had instruments used from that, you can very easily go back and find that. If you're relying on finding them in the patient's health record, it's almost impossible, because unless you've coded it, there's probably no way of being able to search it. And you certainly wouldn't want to code every single load number. So using the book is probably the best way. Some practices I've seen have actually used a really big record book, the kind that they would use in the hospital system. I think that's probably quite over the top, but if you want to, that's great. Exercise book is perfectly fine, but definitely be doing that. Our practice has a defibrillator. So as you'll notice, that is still an aspirational indicator. You do not need to have one as yet, but it is still a really good idea to have it. We do suspect that certainly in the 6th edition, it will become mandatory. I'm actually surprised it hasn't by now. And maybe that's just on reflection of the smaller practices where maybe it's not viable, or they're so small that, and they've got very quick and easy access to a defib, perhaps next door in the pharmacy or something like that, that they can rely on that for now. But watch this space, that's probably going to become a requirement. And 6.1D, our practice, this is really important, so please take notice of this. Our practice has a written practice-specific policy that outlines our cold chain processes. So you must have a vaccine management or cold chain policy. It's got to be practice specific. It must have the actual name of the person responsible for cold chain in your practice. It must have the names of anyone else responsible. It must have information about your fridge. It must have information about your backup system. So say that your power goes down, what are you going to do? That information needs to be in there. So I very strongly suggest you download the template for the vaccine management or cold chain policy and use that template. That is your best way of doing it. Do not rely on just the few pages that are in the main policy and procedure manual. It's not adequate, not even slightly, and you will definitely get a not met if you have not got the proper practice-specific policy. It's a separate one. So do make sure you do that. So that's really the main changes in a nutshell. It's a lot. Not that many of them, but there's a lot of work involved in them, but they're really very important. So hopefully I've explained in a way that you won't find it too onerous and that you can manage implementing them. So next thing, preparing for the 5th edition. What do you need to do to make sure that you are ready? So make sure, we've discussed this one, set practice plans and goals to improve service. Do not forget that. Evaluate your progress against goals. Develop a proactive business risk management system and make sure that you've actually completed some of it. Don't just have a table, actually have some, not just risks that you're planning on addressing, but some that you've actually already addressed. Develop an email and social media policy. Make sure there's 2 separate and distinct proper ones that have been fleshed out. Ensure all clinical team trained to use clinical equipment, and make sure it's documented and make sure they're aware of the risks. Make sure you're seeking input from your team on quality improvement, and please make sure you have a meeting with a standing agenda to help with that. Work towards an open disclosure system. Make sure you're maintaining your equipment in line with manufacturer guidelines and make sure that you're actually documenting all of that. That hasn't changed, it's nothing new, but make sure you're doing it because it does get forgotten. Be aware, and this is a really big one, the fifth, we're much tougher on this now because we have to. Be aware that clinical team may include room rental practitioners. So that includes allied health practitioners, okay? And if you've got allied health practitioners, so that includes your psychologists, your podiatrists, your physios, all of those ones. If they have access to your clinical records, make sure, or you do bookings for them, or you take payments for them, then realistically they should be included as part of the clinical team. So make sure you have their CPD points, some certificates ideally. Make sure they've got their registration, and some of them they're not registered through APRA, so they have it through the relevant body. You don't really need to have their insurance documents, but it's a very good idea to do that and make sure, and this is a tricky one, that you have their CPR certificate as well, a current one. That's a bit of a tricky one to get sometimes. And also that you've done an induction program. Ideally, you would have a job description as well, but that's getting a little bit tricky, but good idea to have something simple if you can. Address the presence of a third party initiated by the practice, really important. Make sure you're addressing it with patients. You've got a system for it, policy should be in place, nothing new, and that you're documenting that in the clinical records. Make sure you complete a self-audit of clinical records based on the clinical record standards and indicators. That is really important, and do that early and then do it again later to make sure that, you know, if there are any problems, you're addressing it well and truly in advance, not leaving it to the last minute. Make sure you track your sterilised equipment if you're sterilising. Feedback, make sure that you're doing it according to the RACGP guidelines. You can now do it yourself, but I really strongly suggest that you outsource it if you can afford to do it. It's a little expensive, but it really is much better that way. It is quite tricky to do it using the RACGP guidelines and doing it yourself. So implementing the standards with confidence. Make sure you know the 5th edition standards inside and out and use your accreditation portal fully. There's some really great stuff in there. Use the self-assessment, that can really help you a lot. Do mock assessments, that kind of thing. Discuss the standards regularly with your team. You really want the buy-in, get them involved with it. Make sure they truly understand and have fully addressed the intent of the standard, particularly for any indicators, criteria that are relevant to them. Make sure you have addressed the must-dos and some of the could-dos. So remember, we're aiming for more than one could wherever we can. Try and go for 2, so at least you've addressed it nicely. Make sure you have all evidence required ready and well organised for the surveyors. So what I'm strongly suggesting now is, so with QPA, you upload all of this beforehand. APRA, you can do that as well now. I really strongly suggest that you upload as much of it as you can beforehand, because it will make it a much more streamlined visit. And during the pandemic, we really don't want the surveyors on site any more than we need them to be. So it's really much better if they can do this prior to the visit. Do a mock survey prior. So use your PHN, accrediting body, do it yourself using the self-assessment, whatever you can to make sure you meet all the indicators in confidence. So I mentioned before about the policy and procedure manual. Do you need to create an entirely new policy and procedure manual every time? No, you don't. And I know so many practices that do a new one every single round of the standards as they get updated. I'm still using, I think it's the 2nd edition, and we have just updated it each time with the new standards. So whatever I know is new, I've incorporated those templates into my one. And because it's so big and it's got so many different policies and procedures that we've set, they've got nothing to do with accreditation. And just because it's a living and breathing document, there's no way I could possibly change it to the 5th. It just wouldn't be worth all that time to do that. So it's definitely okay to do that. Just make sure that you've got all the new elements that you must have, so that you don't find that you're getting not met because you're still relying on an older edition. You certainly don't need to change every policy and procedure either, only the ones that require updating, modifications. So the ones that specifically mentioned, throughout when you're doing the self-assessment and when you actually read the standards. And like I said, remember, it really must be a living document. It works so much better that way. So update it all the time, and then you're not doing the mad scramble as you get to your survey. Now, make sure you don't go through this alone. There's a lot of fantastic help out there. You have got an amazing PHN. I know your team out there is really, really fantastic at helping in all sorts of ways. The phone coming out. They've got amazing templates available. So really use and abuse them in the nicest possible way. Make sure you call your accrediting body for clarification assistance. You pay a lot of money for your accreditation, so make sure you really get the most out of it by getting as much support as you can. Look for lots of resources. So the RSCGP obviously has heaps because they set the standards, but turn to your insurers as well. They have some great stuff there, particularly around privacy and again, social media, email, those kind of things. MPS has got great resources as well. National Prescribing Service, for those that are not familiar. And make sure you look for training opportunities to enhance your accreditation journey. So if you see any training opportunities out there, definitely, you know, join in, do it. At the moment, it's all by webinar. Great that you're already viewing this one. You're off to a great start. So on that training note, this is another failing point. A lot of practices that they provide induction for their staff, and then that's kind of the end of it. You really need to provide more training than that. And it really helps because they're growing and learning, and they can really help your practice when they're more knowledgeable. And it tends to make people more enthusiastic as well. If you invest in them, even if they're free courses, it doesn't matter, it's still invest in them. And so there's plenty of different courses out there. Look for, so at the moment, it really is all webinars and e-seminars. But next year, we'll probably move back to some face-to-face learning opportunities. There's also some more involved online learning opportunities. And you know, UniP's actually got, I believe it's either very inexpensive and maybe even free. It's like an introduction to practice management online course. It's really worth looking into. Certainly AOPM's got lots of resources available as well. Journals, plenty of information in there, and look to other external courses as well. It doesn't have to be within our industry. There's lots of stuff outside of. And make sure you keep copies of the certificates and actually keep trading records as well. That way it keeps you accountable and you're making sure that they're constantly updating. You're not just putting the certificate somewhere and forgetting about it. Communication, we'll have to wrap this up quickly, we're running out of time. Just make sure that you are communicating regularly. Use message books, use your messaging system, have hallway conversation, have your formal meetings to make sure that, again, there's an agenda and minuted, that kind of thing, but really communicate a lot. That's how you're going to bring your team on board, and make sure that it's collaborative and you're allowing them some input. So the common areas of non-compliance, so I mentioned before about allied health practitioners, they're very often not recorded on the profile, so make sure that they are. Immunisation records for each staff member are often being forgotten. Make sure that you actually use the immunisation record template and complete it properly. And that includes flu vaccines, that kind of thing on there. HR documentation is often missing for individual team members, so make sure that you're getting all that documentation. I know CPR is a little more difficult at the moment, but it is starting to become available again. So if you need to do that, make sure you get that done as soon as possible. Business plan, business risk plan not in place, make sure that happens. IT details are insufficient. So some of you may have noticed that the RSCGP Computers Information Security Template has reasonably been taken down from the college website, but it is still there. And if you ask the PHN for it, they certainly can provide you with a copy. I strongly suggest if you've got an IT contractor, get them to help you to complete that. It makes it a lot easier. And hopefully you've got IT contractors now that are overseeing your IT systems, because it's starting to get too complex, too many risks there, and it really is better to have someone that knows what they're doing, looking after that, as well as someone on site taking care of the minor issues. No issues recorded on the near misses and lapse register forms. So please don't tell your surveyor that you've never had an incident in your practice. Every practice has had a near miss or lapse. It could be someone has fallen over, something happened with the vaccines, be it the fridge, you know, went out of range, or that there was a mistake made, either a patient nearly was administered with the wrong vaccine, that is actually an incident, or was administered with the wrong vaccine, needle stick injuries, results were forgotten, all sorts of things could go on that form. And nurses generally are very good at this. They're used to this from the hospital system where they will fill it in at the drop of the hat. You really need to get in the habit of doing that. Fill in that form, because that will become part of your defense should you ever need it if something goes wrong. And it's also really great for learning from. So that quality improvement standing item I mentioned with meetings, if something's happened, if it's appropriate to raise it in that setting, it's a good idea to raise whatever happened, talk about it, and find ways to minimise the risk of that happening again. No issues are recorded on the complaints register or similar, where there's no complaint forms filled in, nothing to show what you've done about it. Again, please don't say that you don't get complaints, because every practice gets feedback of some sort. So you need to show what the complaint or feedback was, what you have done about it. That's really important. Sometimes it'll go in the patient record. An awful lot of the time it's actually not appropriate to put it in there unless it's really of clinical nature. If it was, then that would certainly be something you'd probably be speaking to MDU about, and they will guide you whether it should go on the record or not. Insufficient detail in the progress notes. Make sure you have enough detail in there. Nothing has changed. There really needs to be enough reasonable handover to another practitioner. You should also be coding by now. You should be having enough information in your demographics, Aboriginal and Torres Strait Islander status, cultural background, certainly updated details like phone numbers and addresses, all those kind of things, gender. These things should be second nature by now, but make sure it's happening, particularly when you do your audit. Have a look for that early on. If it's not happening as it should, make sure it is. So just really quickly, this is the evidence required. A lot of you are familiar with it. I'm just going to breeze through this very quickly so I can get to questions. But make sure that you've got all your HR in place for doctors, nursing, admin, reception stuff. Actually, for nurses, allied health, Aboriginal health workers and doctors, you must have ARPA registration. That is the one thing that's different. But then for the entire team, you must have CPD record or status. You must have a current CPR certificate. You must have immunisation status for all of your staff and team. So doctors, nursing staff, allied health practitioners, admin, reception must have immunisation status, must be filled out correctly, must have the immunisations on there. Unless they object to it, but really try to discourage that, try to get them to do it properly. It's in really the patient's best interest, and it's in the staff best interest as well. Job descriptions, you must have a job description really for any type of role in the practice. And you must have induction lists. Make sure you also, I'm going to go to this now, you must have a specific job description with the staff member name for the cold chain coordinator, infection control coordinator, with detail regarding each. So let's say that your nurse typically is in charge of this, but it may be a receptionist or the manager. Make sure on their specific job description, these aspects are mentioned. So it must have cold chain coordinator, it must have infection control coordinator, and it must have information about it. It's not good enough just to say the nurse or whoever's responsible have their name on there so that they know they are accountable for it and what they are accountable for. These are very high risk areas, and so this is a you must, you cannot get around it, it's prescriptive. Make sure you also have performance appraisals or performance discussion documentation available. It doesn't have to be formalised appraisal anymore. It could be just documentation of discussion that's taken place. But make sure those discussions are happening and that you're documenting it and that it's reasonably regular. Really quickly, make sure you've got documentation of home visits and after hours visits, including from an after hours service if you use one, and what you did if it was an after hours service, what you did when you received that report. Any handover of care, so that also includes after hours reports. Results policy, still need to have that, need to have a recall and reminders policy, nothing changed. IT have covered that. Emergency response plan, that is particularly relevant right now. And you will actually notice, just for the AgPal people here, that ironically, even though it states that you must also have pandemic response included in there, it's actually missing that section in the template. So I would strongly suggest that if you're using the AgPal template, that you do in fact add in pandemic and flesh that out. That will be very relevant during COVID. And although you don't need to have a really elaborate policy and procedure or information around it, you definitely need to have it addressed in some way. Email and social media policy, practice specific cold chain policy, and that must again have the person responsible's name in there. And same with the infection control policy. Must have your patient feedback results, must have a patient feedback system. Just going back to results, make sure you have evidence of what you did to communicate with your patients, changes made. Minutes of meeting or other evidence of regular practice communication. After hours agreement, really important, often forgotten. IT supporting documentation. So you must have a backup log, proof that your backup system is working. A blackout kit, make sure you have that available to look at. Equipment maintenance log and certificates, nothing's changed. Cleaning schedule and sterilising or disposable instrument documentation, and also have some disposable instruments available to you if you're doing that. Sterilising, obviously you need your equipment available for the inspection. And just finally, so make sure you have a list of selected records that have home visits, phone calls, after-hour care, after-hours follow-up, and other patient records for normal accreditation review. So your surveyor may choose to go off the beaten track and not use a list, but for the most, they do actually prefer a list. It does make their life a lot easier, so that they're not having to dig around. They can find that information quickly and easily. So just a few quick things about during the pandemic. Make sure you let your surveyor know before they come out if you've had a positive case in your practice within the 14 days prior. Let them know if anyone that they're going to interview has COVID type symptoms. Really, it would be better that they stay home, and then the interview could be rescheduled to be done at a later date, either by phone or Zoom or whatever the accrediting body will allow. Ensure that there is a room available for the surveyor to work from. Please be nice to them, provide some hand sanitizer. They'll bring their own, but good to have a pump and some hospital grade wipes that they can wipe down. You would probably prefer that they wipe down as soon as they go from practice to practice after themselves. And they will have to complete a COVID risk assessment, and they may have to postpone the visit if they have any symptoms or have been tested or been to hotspots. So do expect that that date may have to be moved a little if something like that happens. And same goes if anyone in your practice has been tested, it may have to be moved if it's a key person. And they may choose to wear a mask for the entirety of the visit, and you may wear a mask for the entirety of the visit. So that's really all there is about COVID. So on that note, I think I've well and truly covered it all. I'm going to throw back now for just a few questions. I know we don't have much time, I've talked a lot, but to Alex and to, it's Alex, right, over to you.
Thank you so much, Fiona. There was certainly a lot of information to get through there, and I think your slides will be an amazing backup for people. But there are 3 questions at the moment. So the first one is about allied health and people that are renting space at the practice. So must all allied health room renters have a current CPR certificate?
Yes. Absolutely. So the only exception is if they are truly room rental and they do not access the clinical records, they do not have appointments made for them by the practice, and they do not have any billing done, then in that case you could get away with not having that information. But I really strongly suggest that you actually have that all there, because you never know the surveyor that's going to come out, and it's just good practice to have that anyway. The one thing to note is that if you have visiting specialists, you don't need to do that at this stage.
Okay, great. Thank you for that answer. I hope that answers it for the participant. The next question is referring back to, you've just touched on a previous slide. What about pandemic COVID emergency response policy? So I think you've answered that, but if you wanted to elaborate on that.
Look, I'd really strongly suggest fleshing out a reasonable amount of policy. Now, that's not really required for accreditation. It says that you need a pandemic response policy. So, you know, in its simplest format, it would be, these people are responsible in the practice for this. This is some emergency phone numbers. We will take guidance from the PHU, PHN, and we've got this PP in stock, that kind of thing. But it would be good to flesh it out, just for your own practice's sake. I actually went through, I don't know if anyone knows this, but my own practice actually had a positive case came in, and we actually were one of these practices that got closed down. We didn't wind up on the news, thankfully. And one of our saving graces was that we'd spent a lot of time developing a pandemic policy and procedure for COVID, and spent a lot of time looking into what if and coming up with different scenarios. So it is a really valuable thing to do, but you don't have to go that far for accreditation.
Okay, thank you. The next question is in relation to you're talking about responding to results out of hours. So if you are a practice that has no one rostered out of hours, what are the expectations to manage those out of hours high risk results?
So most of the pathology companies, if not all, have the GP's phone numbers. So I think they're usually mobile numbers, sometimes they're home numbers. So I would imagine that they're actually calling the GP, the referring GP directly. They're probably not ringing a generic practice phone number because that doctor's actually requested that particular test. So in that case, that doctor would have to deal with it. You may have some systems set up where it could go to, say, the medical director or whoever is willing to deal with that, but you must have someone that is dealing with that. You can't just leave it to the path lab to call the patient and say, you need to go to a hospital. That's not acceptable now under the standards. And I didn't write this, I promise, but that's definitely the requirement as it stands at the moment.